Thank you. Thank you very much, Henry, for that introduction. Well, I'd like to present a bit more of a variety of an update about epilepsy. I don't have any disclosures or conflicts. I'll be talking about one drug, one device, which are both FDA approved. I will, it's going to be hard to follow Dr. Hiroki's really superb overview of SARS, but I'll touch on that at the end. I would like to cover several other topics: autoimmune epilepsy, maybe a slight update on that, a new neurostimulation device, the deep brain stimulator for epilepsy, and Xcopri, a new drug, a new promising drug. And then a little bit about SARS-CoV, but again, I'm not sure I'd add too much to Dr. Hiroki's talk. So autoimmune epilepsy, I want to first thank Dr. Kyle Blackburn for sharing this case. He's part of our neuroimmunology group, along with people you might know like Dr. Steve Vernino and Dr. Ben Greenberg. It's really a tremendous group, and they provide us, the seizure docs, with a lot of support, because as you'll see, there's a lot of overlap with epilepsy. So I want to present a case. This is a 59-year-old man presented with seizures. He was diagnosed with thymoma in 2019. It was resected. And then 4 months after the thymoma was discovered, he presented with seizures. The seizures were focal to bilateral tonic-clonic. That's the new term for secondarily generalized, focal with secondary generalized tonic-clonic seizures. He was treated with lacosamide, Vimpat, and did quite well. In fact, he was seizure-free. He was doing so well, they tried to taper him off, but immediately he had a flurry of seizures, focal to bilateral tonic-clonic, and multiple focal impaired seizures. Again, focal impaired is the new term for what you might know as dyscognitive or complex partial. They keep changing the names. Now, if you'll see on the right, you'll see the MRI showing these multifocal T2 flare lesions, non-enhancing, subcortical, but mainly cortical. So now the concern, as you might expect, that, well, this patient must have metastases, but thymic metastases are very rare. I mean, they can happen, estimated at maybe 0.5%. He also started to show slowly progressive cognitive problems. Now, again, as you might expect, they were obligated to biopsy, and it turned out that it was negative. It was gliosis, atypical cells, but no tumor. He also had anti-acetylcholine receptor antibodies, binding and modulating, as well as anti-striational antibodies. Very, supportive of a myasthenic syndrome, except he didn't have a myasthenic syndrome. He had a limbic encephalopathy. The progressive cognitive problems, the seizures, so that there was a disconnect clearly between what he presented clinically, his MRI, and his antibodies. So he was hospitalized during this flurry of seizures, not status, but close. And he was treated with immunotherapy, prednisone, first-line immunotherapy, prednisone and plasma exchange. He's now maintained on Cellcept. After 5 months, he had a remarkable, just a very impressive improvement, essentially normalization of his MRI. Those lesions disappeared. And he was diagnosed with a new type of encephalitis, new to me before I reviewed this, thymoma-associated paraneoplastic encephalitis, or TAPE. Now, according to our neuroimmunology group and Dr. Blackburn, they strongly suggest this is a new type of, relatively new type of, and nothing's new, that's in the eye of the beholder, but a new type of autoantibody, GABA A. And the reason they suspect it is because of the thymoma and the MRI. And it turns out this antibody is not commercially available. So it has to be sent to research labs. And because of COVID-19, that has been delayed. So I want to step back a little bit and just show a sort of a wide view, a sort of a spectrum of what we know about epilepsy and autoantibodies. And I want to sort of clarify some of the terms. So my conceit is if anyone has seizures, it's autoimmune epilepsy, but they may not have seizures, and we might call it autoimmune encephalopathy with cognitive problems, personality changes. Paraneoplastic, clear, there has to be a cancer, a tumor that's not necessarily a cancer, but a tumor that's producing these autoantibodies, driving the antibodies. And encephalitis is also defined specifically largely on CSF MRI abnormalities. But you can see that we've had autoantibodies since 1965. We have a total of 26 now. And this GABA A is one of the more recent, but that was first described in 2014. So it's not that new. But even now, we don't have a serum test for it. I want to highlight the work of Dr. Dubé, who was our resident, worked with our neuroimmunology group now at the Mayo Clinic. He developed this two scorecards, which I think could be clinically helpful. The APE, or antibody prevalence in epilepsy, and now it's antibody prevalence in epilepsy and encephalopathy, sort of combine them together, and probably encephalitis. And when you go through each of these symptoms or presentations or exam results, a score of greater than or equal 4, you should be very suspicious of an autoimmune process. And the sensitivity and specificity is very high. Sensitivity is like 99%. On the other hand, he also developed a response to immunotherapy in epilepsy encephalopathy, which says, well, if you have a score greater than or equal to 7, this patient is probably going to respond well to first-line immunotherapy, steroids, plasma exchange, immunoglobulin. So these might be helpful in sort of assessing patients, especially in a somewhat confusing case as this one is. And just to step back again, so we frequently turn to the Mayo Clinic's encephalopathy panel. That there is an epilepsy panel, but the encephalopathy turns out to has everything plus. And there's also a paraneoplastic panel, which is much, much more limited. So in this encephalopathy panel, 21 antibodies are tested. You can get it on serum or CSF. Typically, the serum is higher yield, but some are exceptions. And NMDA, N-methyl diaspartate receptor autoantibodies, and GABA A, the one I'm presenting, actually have a high CSF yield, and it's very worthwhile to add that. Now, again, the GABA A is not available. So a little bit about GABA A was first demonstrated in humans in 2014. There were 50 human cases published up to this very nice review by Wu in 2020. And it's thought that, we're familiar with the GABA receptor. It modulates the chloride channel for inhibition, neural inhibition. And it's thought that what happens when you have an autoantibody attacking this channel, this GABA receptor, it internalizes the entire channel. And that means they're not there to inhibit, and you get subsequent neuronal hyperexcitability. And the important thing is early diagnosis for treatment, especially for tumor recognition and treatment. Now, the median age is about 40, but there's a wide range. Seizures are very common. Status in half of the patients present with seizures. Encephalopathy, very common. They have a wide range of psychiatric symptoms, sometimes called brain on fire, a famous book now about patient who presents with hallucinations, thought to be, a new onset of schizophrenia, turns out to be autoimmune. And they can have movement disorders. And these are difficult sometimes to separate from seizures. As you probably know, that seizures, simple partial seizures, focal motor, often lack a scalp correlate. Here's a patient we just saw in the hospital I helped take care of with what we think is myarrhythmia in NMDA encephalitis. And you'll notice she is just this is one of the more mild, but this very chaotic, blinking, eyebrow raising, mouth, tongue, constant. Again, no scalp EEG correlate. We quickly concluded this really isn't seizure, and they have dysautonomia. Now, 12% have an infection or fevers as a trigger, 32% neoplastic, and a large percentage, strong predominance for thymoma, among others. CSF shows the inflammation, the pleocytosis, elevated protein, and oligoclonal bands. Again, if you check both serum and CSF, 90% positivity. MRI is characteristic. These multifocal flare or T2 lesions, they're non-enhancing and mostly cortical based, but some subcortical. The EEG, as Dr. Roki pointed out, it's very nonspecific, 94% abnormal, but very high number with epileptiform patterns. Nothing pathognomonic, meaning diagnostic, unlike NMDA, again, to come back to that classic disorder, autoimmune encephalitis with delta brushes, which you see in that patient that I showed the video on. And of course, first line, second line, outcome variable, some with very poor, some good. Again, faster treatment, more important. And I want to end this section to just think about the spectrum. People have been doing it a while, like Dr. Roki and me. You know, we've always responded, recognized it, you know, back to when we started in the 80s or 90s, these explosive onsets, brain on fire, immediate hospitalization, and we hit them with immunotherapy. They might present with NORS, new onset refractory status. And then at the other end are just patients with focal epilepsy who are well controlled. Do they have autoimmune? Is it worth testing them? And in the middle are people who are pharmacoresistant. We always test them. The APE and the right scores may be helpful in sorting this out. Okay, now I want to talk about treatment, a relatively new treatment or deep brain stimulator. And I want to introduce a colleague of mine who shared this case. I took care of the first monitoring, and Dr. Doyle is following this patient. This is a 53-year-old man with pharmacoresistant epilepsy. That's defined as failing 2 anti-epileptic drugs done correctly, expertly, since age 13. His MRI to the right shows a really classic example of schizencephaly, these clefts in the brain. They're lined with polymicrogyria. It's a form of a disorder of cortical malformation, or very epileptogenic. He has no focal aware seizures. Again, that's the new term for auras or simple partial seizures. He has staring spells he vocalizes, he has bimanual automatisms. Amazingly, he, of course, on medicine, he never progressed to a secondary generalized seizure. He's failed 13 drugs. He had the VNS, which is somewhat effective, but not totally. He has a baseline seizure rate of 10 per month. So we put him through a phase 1. He had diffuse, some of the seizures were, when they were localizing or lateralizing, they were frontotemporal. Some were not localizing. He had a very characteristic low voltage fast activity, and that's characteristic of neocortical as opposed to hippocampal or mesial temporal epilepsy. And it fit with this type of cortical malformation. Interictal, all was on the left frontotemporal paroxysmal fast activity, delta slowing, fMRI. He actually had switched his language. Probably happened early, more right than left, but bilateral. PET was bilateral, not helpful. Neuropsychometrics, not helpful, not localizing, just generalized dysfunction. And we routinely now do a magnetoencephalogram that can pick up these dipoles equivalent to spikes in deep areas. And they were maybe falsely lateralizing on the right temporal. So we decided he needed a phase 2 or stereo EEG, where our surgeon, Dr. Lega, puts in up to sometimes 20 electrodes. We favored the left side, as you might expect, 17 electrodes, 8 left, 3 right, 192 contacts. And it was a bit disappointing. We were hoping for a focal onset, but they were covering a huge area, right from front to back of the temporal lobe, from the entorhinal, temporal pole, all the way back to the fusiform gyrus, which is really temporooccipital region. And these are 4 EEGs covering all the SEG, showing that it was not in one place. They were simultaneous, extremely fast propagation, not surprising. But what do? Well, we use sometimes it's considered pejorative, but it's really not, palliative. So these devices, which I'll review in a sec, the other ones are considered, palliative. And it is true, surgery has a better chance to cure. There's no question. We try to give the patient that option. This patient didn't have that option. It was just too large a network, and we couldn't do responsive neurostimulation or neuropace because, where do we put the electrodes? Again, too wide. So he had an anterior thalamic deep brain stimulator implanted in April in the spring of 21. Dr. Lega is our neurosurgeon, does a 2-stage process. First puts in the thalamic electrodes, and then later, about 2 weeks later, puts the generator under the clavicle. We continued with this device. You actually can continue. So we've got 2 neurostimulators, VNS and DBS. Unfortunately, he has not had really any change. Dr. Doyle says that they're milder, which is good news, but this is a work in progress. So the engineers at Medtronics help us, help Dr. Doyle to program it. And so it's step by step. And meanwhile, we're hoping for neuromodulation. So some change, which we don't know what the cause is. This is a great article by Ryvin and Hirsch. Hirsch is a very famous epileptologist, just published in Lancet Neurology. Very nice review, looking at and trying to contrast and compare the VNS, the RNS, and the DBS. So it's a good reference article for a patient you're trying to counsel. So the thalamus is our target. And why the thalamus? Well, the anterior thalamus is part of PAPE circuit. It's the memory and emotional. And as you'll see, that's one problem, downside of, or side effects. And so it was thought this would be a prime target. We're still in the search. The holy grail is we'll find a subcortical nucleus that will turn seizures off. That's the holy grail. Now, what's the mechanism? Well, we don't know. We think of the thalamus as sort of the grand central station for propagating electrical seizure impulses, but we don't know how it's done, how this neuromodulatory effect takes place. That's an area of research. So a little bit about the Medtronics. It was approved in 2018, Medtronics thalamic stimulator, approved in 2018. It's for adults 18 or older, partial onset seizures, refractory to 3 ADs. Usually it's 2 for pharmacoresistance. Bilateral anterior thalamic nuclei are targeted. They have a new version just approved of Percept, and that gets into the weeds of the engineering. It's not unlike the VNS. So now we have, instead of voltage, it's millivolts, but we start low and we start increasing it. We can change the electrode configuration. In other words, what electrodes are being stimulated to what. Again, gets into the engineering details, and we can change the cycling. Typically, it starts at 1 minute electrical stimulation on, 5 minutes off. And Dr. Fisher supervised a large trial, 110 patients, found that not only did you get an acute reduction, but after 2 years, there was a very robust responder rate. By the way, the responder rate is unique to epilepsy. It's a way of saying, is this a significant, meaningful improvement, which is the percent of patients who reduce their seizures by at least 50%. There were no symptomatic brain hemorrhages. Sometimes there's a small hemorrhage where you put in the electrode, but nothing significant, no CNS infections. But again, not surprisingly, because the anterior thalamic nuclei are part of PAPE circuits from hippocampus, fornix. And so that circuit is memory and emotion. So memory and depression were more prominent in the stimulated patients, but good news was that it improved with time. And a follow-up of Salanova did a 5-year follow-up and showed a improvement in the responder rate, very, very robust, close to 70%. And not only that, 16% of patients were seizure-free for at least 6 months. I'm not sure how to interpret seizure freedom. They all describe it differently. If you're, I don't think anyone has been seizure-free for the whole time, but there are large chunks. That's an improvement. And the future, and this is off-label, but we're not doing it. But in any case, we're looking for other nuclei. And even Dr. Lega feels that for a patient with generalized epilepsy, again, off-label here, but allowed to do it, centers are doing it now, put the electrodes in the central median thalamic, and perhaps that's going to be better. We don't know. Again, the holy grail is find a nucleus that's going to have, just shut it down, shut the seizures down. Here's a kind of a summary chart, but modified from Schultz and Bonhage, which I found really helpful. And if you look at the 3 treatments we have and compare and contrast the risks versus the benefits, you'll see they all have a robust 60 to 70% eventually in 5 years responder rate. There is a belief that DBS and RNS may have a better chance of seizure freedom. I'm not so sure, but it kind of looks that way. In fact, the DBS had an 8% chance of, or 8% of the patients had 2 years of seizure freedom. Again, that's meaningful. That's very meaningful. Risks are on the right. I won't belabor it, but it's a safe, our devices are safe. VNS would be at one end, and probably RNS where it's a full craniotomy, putting in device. Actually, sometimes you can just put in the probes. Now, I know this is from Levanova website, but I found it really helpful. That's Dr. Fisher. He's just a great expert and a leader, opinion leader. And I think he did a really nice balanced view of these 3 neurostimulators. And he has a chart that, again, I found very helpful, very fair and unbiased. So I think it's something you can refer to if you have a patient trying to decide which of these devices works for them. Again, we aim for surgery. We aim for laser destruction, resection, something that will take out that focus. But as in this patient, too big an area, we couldn't do it. Okay, I want to now talk about a drug. That was a neurostimulator using, fire to fight fire, so to speak. But a new drug came out, relatively new, and I was impressed when I came across this review by Jacqueline French. She's again a very, very prominent, a well-respected investigator in drug trials for epilepsy, and I thought it was interesting. She called cenobamate, Xcopri, a possible game changer, and you'll see why it was impressive to her. So Xcopri was FDA approved in 2020. It's approved only for adults, focal seizures, monotherapy or adjunctive. So that's nice. Monotherapy is often not the first approval. It has a carbamate functional group, which I circled there. It may remind you of other drugs, felbamate and topiramate. It's now Schedule 5, which creates a hassle for clinicians in ordering. We can only order so much. It's just a hassle. And, the FDA demands that they give either normal people or people with a history of drug abuse, and they give them the drug and say, hey, did it make you happy? And if they said yes, Schedule 5. Krauss et al. Did probably, I think, the first pivotal study that showed, again, robust responder rates at 200 or 400. And here was what I think impressed Dr. French. The seizure freedom rate at 400 was really astounding, 21%. Now that's short, that's 12 weeks in a typical trial when they're blinded, it's controlled, 21%. And other trials never have reached that. Looking at all the other trials, it was maybe 3 times the seizure-free rate. So whether that'll turn out in real life, who knows, but it was impressive. Maybe it is a game changer. As you might expect, you pay a price when you increase the, for that seizure freedom at 400 milligrams or 200, you increase serious, severe adverse events and you increase dropout. So if the patient drops out, stops the drug, it doesn't matter how seizure-free they were going to be. They can't live with it. So what's the mechanism? Well, there are probably 2 mechanisms. It's not precise. None of them are precise, but one is attacking or affecting the sodium channel, the excitatory part of the, yin and yang, and then the chloride channel. So for the sodium channel, it seems to enhance slow and fast inactivation, which will reduce that repetitive, extreme, rapid firing at the sodium channel, causing hyper-excitability. It also seems to be a positive allosteric modulator, and that just means that it increases by binding of this drug to the chloride channel, it increases the chance that GABA will bind and open the channel. And when a chloride channel open, you get inhibition. So 2 mechanisms, which is nice. Maybe that explains why it's maybe more effective. Well, there's a couple downsides that I think, hopefully taken care of. But in the early studies, one patient died because of dress. And I kind of lump all these together, Stevens, Johnson's, TENS, dress. They're all these terrible, not just rash, but lymphadenopathy, facial swelling, organ failure, myocarditis, myositis. And one good, clinical pearl is they don't always present with a rash. So if they have mouth sores, facial swelling, we all get, nausea and vomiting early in the titration, that's suspicious for one of these systemic allergic reactions. In the first 953 patients, or 0.3%. Now, in contrast, now we think of Stevens-Johnson with a slow titration is probably much less than 0.1%, 1 in 1,000, probably more like 1 in 5,000. So that was worrisome, and they addressed it in the next 1,300 patients with a very slow titration. So you have to titrate this specifically, exactly how the company wants it, recommends it. It also can shorten the QT. Now, most of us struggle with QT prolongation. That's what worries us the most, but there is a problem with shortening it. And these did have a significant shortening compared to placebo. However, it never got below a total of 300 milliseconds, which is the red zone. That's where you could introduce ventricular arrhythmias and sudden death. You cannot give it to people with a familial short QT for obvious reasons. Of course, with any drug, depending on your titration speed and the genetics of the pharmacogenetics, genomics of the patient, it's non-specific. But this one, and a lot of people will be happy about this, is decreases appetite like zonisamide or felmamate and topamax. So topiramate, they all have in common these carbamates, which are appetite suppressants. You can see an increase in potassium. You can see ALT changes. So maybe worth checking some labs midway through the titration and at the end. And all the ADs have a risk of mood worsening. It's hard to predict, some more than others. Protein binding won't be a problem. It's too low. The half-life is long, so that means it's a once-a-day drug. Volume of distribution means it doesn't go to fat. It's basically distributed in our body water. And if for hepatic and renal impairment, you have to be a little careful and lower the dose. No one on dialysis can get this. And here's the major problem, I think, or not a problem, it's just you have to be careful because unlike some of our drugs, say gabapentin, pregabalin, levetiracetam, this drug has a lot of drug-drug interactions. So you could introduce kind of a well-known paradoxical worsening of seizure control with the administration of an anti-seizure drug. So how does that happen? Well, one way is they're doing pretty good on lamotrigine, but not perfect. and we're aiming for perfect seizure freedom. So we add another drug like cenobamate, and it lowers lamotrigine, and we lose seizure control. We lose that benefit. So you have to be careful. You have to check. I always check a baseline and get a nice baseline before adding a new drug in case there is this problem. And that also is true for carbamazepine. A big problem would be oral contraceptives in a young woman. So you have to either consider a non-oral contraceptive or double methods or raising the strength. So it gets complicated. Have to worry about some cardiac drugs, antidepressive, and then, drugs like cyclosporin for transplant. So these are all worrisome and may decide to avoid this drug. Now, drugs will also increase when you add Xcopri, and that's could be a major problem with phenytoin and phenobarbital. It also increases the active metabolite of Onfi or clobazam, and dangerously, it might increase warfarin. So with hemorrhage. So the only drug so far known is phenytoin, but probably phenobarbital, not by 13%, but phenytoin would be more significant. Will decrease Xcopri. Not much known. It's what I think used to be called category C because it does affect animals. We don't have any data on humans and breastfeeding at this point. And again, it's monotherapy or adjunctive, but you have to follow this guideline to the letter. And if you do, there's a good chance that we won't run into problems. Okay. I want to end with add a little bit to Dr. Roroki's really nice coverage of the neural effects. It's a tricky subject. I think Dr. Roroki highlighted it. When I looked at PubMed, I kind of grimaced. I thought, oh, this is more, bit off more than I could chew. There's over 600 articles. And as Dr. Roroki mentioned, a lot of them are case reports and meta-analysis. It's a young research area, so there's more to come. So I don't profess any hardcore conclusions. I think we're going to learn more. One problem is selection bias in the sense that someone comes in the hospital or presents, they're sicker, and the sicker patients get EEGs. So we're already biased in that way. The more they're sicker, if they have encephalopathy, they're going to get an EEG. They're going to be examined more closely. They may get continuous video EEG. Another is it's very difficult to sort out what's specific neuroinvasive, neurotropic effects of this virus and what's just the non-specific effects. Again, as Dr. Roroki showed, there's all sorts of different things going on with strokes and cerebral venous thrombosis. These all cause seizures. Seizures are like fever. That's non-specific brain injury, provoked. I can't say much about epilepsy. I don't think there's enough time. That takes a while. Epileptogenesis, the old British called it the ripening of the scar. So it takes a while for epileptogenesis to happen, maybe a year or two. So we're not quite there yet. Maybe this long COVID syndrome will have epilepsy as a consequence. I'm not sure that's present so far. And I want to share with you kind of this idea of the spectrum where you have some things that are low neurotropism, low neurovirulence. And I do think SARS-CoV, I know there's no evidence from pathology, but I'm sure it does invade the CNS. I think that, based on antibodies in the CSF, based on pleocytosis, it seems to have access. But, coronaviruses have been around forever, the common cold. No one gets a seizure with that. At the other end, if you have herpes 1 encephalitis, you're probably, a third of people present with seizures. They present, and it's not due to anything else but the virus. Middle Eastern respiratory syndrome, coronavirus, 9% seizures. Interestingly, a recent article out of Germany where they looked at adults with influenza, no adults had seizures, but kids did, 2/3. Actually, this was in a WHO review, that 2/3 of kids with influenza A or B presented with febrile seizures. That's clearly a selection bias, because those kids, all children at the right age, a year to 6 months to 6 years, they're vulnerable for febrile seizures. So that'll bring them right in. They'll get maximum attention. So where SARS-CoV-2 comes in the spectrum, I think remains to be seen. So like Dr. Roki did, I really relied on meta-analysis, and it sort of fit with what he pointed out in that nice neurology review, the most recent, of about 1% incidence of seizures. So not high, despite all these ischemic stroke. So we're thinking these are provoked or acute symptomatic seizures when they have meningoencephalitis, hemorrhages, ischemic stroke, but not really a super high prevalence, at least compared to other viruses like herpes. Here was another review out of Iran where they looked at, over 6,000 patients, and they were all very sick. 4 out of 5 died. All three that they studied, very minimal investigations, but the 2 of the patients, and 2 had CTs, 1 had MRI, they had strokes. EEG was non-specific. Now, turning to just the EEG findings, this is, again, selection bias, because the sicker patients are going to have epileptogenic findings, and that covers about 6 categories: pure electrographic seizures, electrographic status, epileptiform discharges, GPDs, generalized periodic discharges, LPDs, lateralized periodic discharges, and lateralized rhythmic delta activity. If you add it up in this study, 40% had epileptogenic EEGs. But who got the EEGs? It wasn't, these 380 patients were culled out of a huge number. So the denominator is not clear. And I want to show you what they're talking about. This is a classic spike and wave in the left temporal lobe. That's obviously increased the risk, but not acutely. GPDs, generalized periodic discharges, that's a tough one. They technically increase the risk of seizures, but they cover a wide range of etiologies, from the famous hepatic triphasic waves of hepatic encephalopathy, which has very little risk of seizures, or CJD. I've seen of course, in CJD, they might have myoclonus, but not really seizures. LPDs, very high risk. 50% are going to have subclinical or clinical seizures. So the LPD is far more epileptogenic. And lateralized rhythmic delta activity, and we subname it by where it is. This is TERDA, temporal intermittent rhythmic delta, also epileptogenic, increased seizures. Now, the same article looked and showed, again, as Dr. Roki showed, very high incident, 90% non-specific, with something called GRDA, generalized rhythmic delta activity, and no pathognomonic patterns, like delta brush in NMD encephalitis. And GERDA, that's the new term. We used to call it FIRDA, frontal intermittent rhythmic delta. Now we just say it's generalized, and so on. Now, here was one study that looked at, again, culling from a huge number, probably, of those that got routine or continuous video EEG. And they found an incidence of about 13% had seizures. Again, half of them had epileptiform activity. And these patients were, they had clear indications. Encephalopathy, not explained by, hemorrhage or stroke or other things, and suspicion for already having seizures. Okay, well, let me summarize. I tried to give a little variety, not sticking just to the SARS, but the GABA A receptor antibody, it's not really new, but we don't even have we don't have a commercial lab that's doing it. And I think the message from that story, at least to me, what I learned is you really have to put the whole picture together, the presentation, MRI, CSF, everything comes together, because you may not have an antibody. They keep getting discovered. And so each year maybe we'll discover a new one. The GABA A is only available in research, so we can help get our immunology group is really helpful in that sense. They know where to send it. It's similar to other autoimmune epilepsies with, the limbic changes and seizures, psychiatric, but the presence of thymoma and these particular cortical non-enhancing flare lesions, T2, that's a big clue. And I think Dr. Dubé, he's our favorite. He was trained here and now he's become a superstar, but his APE and RIGHT scorecards may help to decide who do you test, because it's expensive. We may be wasting a lot of money, people who don't need it. Really, I didn't add much to what Dr. Roki showed, but I do think it's neuroinvasive. Risk of seizures is low, but EEGs are common, again, in the people are almost always really sick. And there might be a lot of reasons for it. So, the hospitalists, I'm sure, just know how to, they just go to expect, are prepared to expect anything. So it's hard now to sort out what's specific to the virus and what's just other features of a can be a very severe illness, and don't know much about epilepsy. DBS is an option. It improves quality of life. It might not create seizure freedom, which is what we aim for, but it improves quality of life and it reduces sudden unexpected death in epilepsy, which may be it's obviously important. Choosing between them is multifactorial, and we just do it. We just focus on each patient and their risk assessment, risk tolerance. Like VNS is less risky than intracranial studies. We have a new drug, cenobamate. It has very robust responder rates and seizure freedom. We'll see how that pans out. We'll all have the experience for those who use it. Just remember, slow titration. Don't give it to anyone with a short QT.